Welcome back, listeners, to Diversion Insights. My guest today is Dr. Rebecca Payne. She is the medical director for the South Carolina Recovering Professionals Program. Some of you know I'm kind of working my way through the states and their recovery programs. And so today we're going to learn about South Carolina. Dr. Payne, welcome. Please tell us a little bit about you and your professional journey up until this point.
Sure, absolutely. Thank you so much for having me, Terri. I'm really looking forward to this. I actually joined the South Carolina Recovering Professional Program about, it was in the middle of the pandemic, so in July of 2020. But prior to that, I'm a psychiatrist by training. And completed my general psychiatry residency training at the Medical University of South Carolina. I fell in love with the treatment of addiction at that time and completed an addiction psychiatry fellowship there. And then I went into practice both on an inpatient unit and outpatient clinic, treating comorbid psychiatric and mental health disorders at the University of South Carolina in their department there. While I was in the department, because of my expertise in addiction psychiatry, I began receiving referrals to evaluate professionals that had the potential for impairment. And that introduced me to a field, I previously had little experience with, and just really began enjoying that type of work. And so I actually shifted gears, if you will, and completed a forensic psychiatry fellowship in order to bring these two things together. And then shortly thereafter, joined the Recovering Professional Program in July of 2020. I thought working in that capacity brings, psychiatry, addiction psychiatry, and then the ability to evaluate and look at things objectively all together very well.
Sure. Yeah. So I'm curious, because of your history with mental health and addiction and comorbidities, just anecdotally, do you feel that mental health issues are getting worse? I mean, you hear that. It's like, oh, it's worse, it's worse. I don't know if we're just more aware of it and more in tune, especially after COVID, where, people were maybe speaking up a little bit more. Do you feel it's getting worse?
I think it's a mix of all of those things. Obviously we can't ignore the impact that the pandemic has had on our collective mental health. Mm-hmm. But I will say, even pre-pandemic, as I was teaching medical students and residents, I often said, I believe that comorbidity of mental health disorders and addiction was the rule rather than the exception. Mm-hmm. You just had to be able to, interview the patient and ask the right questions regarding the mental health component. And so, yeah, I mean, they're so highly comorbid with one another. I do believe, though, that the pandemic has allowed, and post-pandemic, people do seem a little bit more willing to talk about mental health and the impact of mental health. So my best guess is it's probably sort of a myriad of those factors coming together that we are having more conversations about mental health, which is obviously a good thing.
Sure. Yeah. Probably always been there. Maybe some managed their mental health better prior to the pandemic. And then, of course, it's more acceptable, shall we say, to talk about it now, because it's not just you feeling like you're alone. Everyone is saying, oh, this has affected. So people, I think, are more open to talking about it, I guess. All right. So tell us about the program. What licensed professionals does the South Carolina Recovering Professional Program cover?
Sure. So we are a state that actually covers all the healthcare professionals across the board. So in theory, we could potentially manage licensees from 30 different boards.
Wow.
So in theory, we don't have licensees from all 30 of those boards at the same time. Our largest representation is from the Board of Nursing, Board of Medicine, Board of Dentistry, and then also from the Board of Pharmacy.
Okay. Yeah. I know Board of Dentistry has always fascinated me a little bit. I should probably have somebody on that can really speak to that field. They don't have access necessarily, right? So I would guess it's mostly prescription writing for themselves, or
Well, it depends on what type of anesthetic they use in the office.
oh, true.
So it could be, nitrous oxide availability and
Okay.
accessibility. And then obviously there's, the prescription writing, you know, alcohol being freely accessible
True.
to all.
True.
We see that quite a
Yeah.
bit in that profession as well. So there is some accessibility depending on the person's practice setting.
Okay. All right. Yeah. Because I know they do. I've heard that more than once. They represent a pretty high percentage, which, okay. Yeah. I find that a little bit interesting, but we'll dig into that another time.
Yeah.
What is the mission of your program, and what aspects of the recovery does it include? Assessment, treatment, monitoring, that type of thing?
Sure. Yeah. So our mission as the South Carolina Recovering Professional Program is to return the professional to safe practice. A corollary to that is obviously also protecting the public.
Mhm.
And oftentimes those two things, more often than not, they go hand in hand. So, but we are an alternative to discipline, if you will, program, meaning we take people who are referred from their boards. We also take individuals who voluntarily come to us. And depending on the circumstances, they can participate in our program and remain anonymous to their board throughout the duration of their monitoring. We usually have somewhere about 30% of voluntary participants, but I can talk a little bit more about that in a minute. In terms of what we do, so we are an entity that we assist the Labor and Licensing and Regulation Board of South Carolina. So when they refer someone to us that has a potential, or there's a concern about potential impairment, we do take information from, the referral source, and that can be a host of different places or entities, and determine what problems may be present. Sometimes that's very clear, sometimes it's not. And then we do, refer for an evaluation that can look into some of the factors and then determine whether there's a diagnosis that would warrant monitoring with the South Carolina Recovering Professional Program. So I always like to point out that, we don't offer the treatment. We act as, sort of a liaison, if you will, between the board and the participant. And our goal in that capacity is to get that person back to safe practice and protect the public.
Okay. So I imagine then you also are involved. If they come to you, you're doing that full assessment, and you may turn them back out and say this person does not have a substance use disorder. So the investigation that is going on, that's your professional opinion. There's something else that's a practice issue or what have you.
Absolutely. And we actually have looked into that. And this data is a little bit old, I believe 2018 to 2022, that 5-year period. But we did look into, about 15 to 20% of individuals who are referred to us actually didn't have a diagnosis that warranted monitoring.
Okay, interesting. And how can you give just a little bit of insight? Obviously, you're the experts. I'm thinking about I perform an interview and I'm talking to somebody and they just no, and I'm like, okay.
Mm-hmm.
What goes into that assessment? I mean, I guess I mean, my real question is, how easy is it for them to fool you that they don't have anything going on?
Well, and so I think, it is dependent upon the allegations that bring the person to us, or if
Sure.
this is someone who, acknowledges that they have a problem and comes to us on their own or in referral from their employer. But oftentimes, so the evaluation can vary. I do conduct some of our evaluations in-house. But when I'm looking at someone, I'm going to consider, what is the allegation? I'm going to look at the toxicology that is available. And we typically do get initial toxicology as part of the intake process. If there's collateral informants that they would permit us to speak with, we do that. We can also, request review of any medical records or treatment that they may have had, especially if the, substance in question may be something that they were prescribed or potentially could have been prescribed and that sort of a thing. So depending on the evaluator and the circumstances of the case, medical record review, looking at toxicology, considering collateral informants. And then obviously the clinical interview and history is very, very important. And then there was sometimes psychological or neurocognitive testing is also involved in that initial evaluation. Usually that's if there is some concern regarding, cognition, memory loss, et cetera, and so on.
Okay. All right. So yeah, you have access to a lot of things that somebody in my position certainly wouldn't. And then I don't have the expertise either for that piece of it. Okay. That sounds great. Now you mentioned that the referrals could come from the licensing board, or a person can come directly from you or to you. If it comes from a hospital, are hospitals required to report to the licensing board, or can they go to you in lieu of the licensing board?
It depends. You're going to hear a lot of it depends, simply because, in the Practice Acts here in South Carolina, it is divided by the different disciplines. And so nursing does have some statutes for required reporting, and the remainder of the disciplines, refer to the hospital's regulations, also to typically the major organization for that discipline, their ethical code, such as the AMA or what have you. So we can get referrals in. It really can run the gamut. I would say, usually when it's an employer, it could be the human resources, it could be from the employee assistance program if they identify an issue that they don't feel like they're capable of managing. Sometimes participants come on their own for various reasons, right? The prompting of a spouse, for credentialing reasons, all of those types of things.
Okay. So the only sure way that the licensing board will not find out, because I believe you said that you won't tell them, right, is for if somebody comes to you directly before there's any involvement with the employer or anything. Is that correct?
Let me make sure I understand your question. So for somebody that comes voluntarily.
Yes.
Yeah. So voluntary participants are handled a little bit differently according to their board's preferences. As a general rule, if somebody comes into us voluntarily and they, maintain adherence and they're doing well in the program, those individuals can remain unknown to the board throughout the duration. Now, you can get into some nuances when there's, issues of problems in terms of at what point does that individual then become known to the board. But that varies quite a bit. And obviously, the circumstances under which that would take place could vary. We try, obviously within reason, to I won't say assist, but I guess that's fine, try to be very clear with those voluntary participants, what would the circumstances be in which you would not become at which time you
Sure.
would then become known to their board.
Okay, sure. Well, keeping in mind your mission of getting them safely back to work and protecting your patients, I suspect that if somebody came in voluntarily, went through the program, was successful, participating, everything looked safe, then they could remain unknown
Correct.
to the board. But if it looked like this might be, they're relapsing, they're struggling, they're not participating, what have you, then it's your duty to report them to the board because it's a patient safety issue at that point.
Yeah, that's
Right.
exactly
Okay.
right. But
Okay.
generally, if they're doing what's been asked of them and things
Right.
are going, fine, they remain
Right.
unknown.
Right. You give them that opportunity to remain unknown. In your state, do you know, and it is maybe different, I know some states, once the licensing board is made aware of it, whether you end up back at work or not and your license cleared, it remains on your license that you had that history. Are you aware? I guess let's just focus on nursing. If that's your biggest.
Well, the board actually has discretion whether the final order is public or private. And so they, I've seen them issue both. And again, it sort of varied depending upon the circumstances. But there is the possibility that, there's a private order issue, and that's not something that is privy to the general public.
Okay. And if it is public, does it remain there forever?
That's my understanding.
Okay. All right. Yeah. Okay. So you mentioned your program doesn't participate in the treatment process, but how does it handle the monitoring process in terms of medication assisted treatment? That's kind of a hot topic, right? Like, is it okay to go back to work on MAT? So how does your program handle that? And what does the monitoring look like, if any, if they do go back on MAT?
Sure. And again, in South Carolina, we do manage many different disciplines, so it varies between. I'll talk about the Board of Nursing's approach. And actually, to do that, let me back up a little bit. So it was several years ago. I think it was late 2020, early 2021. We as RPP and some representatives from the Board of Nursing at that time formed a subcommittee to look at this issue and see, what monitoring would look like if someone was on medication assisted treatment. And actually, I'm going to be more specific and say buprenorphine. So that was the particular MAT that was considered by that subcommittee. And so over time, and several meetings, we were able to outline what that would look like. And then that was presented to the full board for approval. And the full board did approve their licensees to monitor while on buprenorphine under our program. And so your question, I believe, was, what does that look like? And so, some of it depends on how the person comes in. Sometimes somebody comes in already on buprenorphine. And at that point in time, we would be able to look at, how long have they been on it? Has their dose been stable? What their treatment courses look like, et cetera, and so on. Also to the evaluator, when they come in, that initial evaluation would consider those factors as well. That scenario is a little bit different than if somebody, for instance, there was an allegation regarding diversion of an opiate of some sort, and they were found to have an opioid use disorder and recommended for treatment with buprenorphine. So, the process from that point would be, they are expected to stabilize on a dose and have a prescriber that has, training in the treatment of addiction. Once that dose has been stabilized, and that time frame, there's no specifics regarding that time frame. It's how long has the person been on it, and then whether it's considered stabilized or not is between, the participant and the treating provider. And so at that time, when it's determined to be stable, the Board of Nursing did make a request that some neurocognitive testing take place to ensure there was no cognitive impairment at that particular dose. And then, once the participant completes that, assuming it was successful, they are able to, they're monitoring with us through this process. And then they would monitor almost as if it was, any other substance. We do test for the presence of the buprenorphine. Not every single toxicology test, but, randomly from time to time. And then oftentimes are in communication with the prescriber, particularly if there's any, concerns or anticipated medication changes, that sort of a thing. But we maintain that communication and then test for the presence of the buprenorphine, and then any other treatment recommendations that may have come from, their evaluation process. We would follow along with that.
Sure.
Yeah.
How long do you typically continue to monitor?
Well, in South Carolina, so it depends. And, one thing too that I didn't point out earlier, and I should have, South Carolina, traditionally, we started in 2000, and from 2000 until 2020, our program only monitored for impairing substance use disorders. In 2020, our scope was expanded by labor licensing and regulation in our state to include not only impairing substance use disorders, but also potentially impairing mental health disorders, and also some professional issues, etc. So in terms of monitoring and the duration of monitoring, if we're just talking about a substance use disorder, that's driven by the severity. So, according to the Diagnostic and Statistical Manual, the 5th edition, DSM-5, mild, moderate, or severe is outlined. And so depending on what the severity of the substance use disorder is, that can inform the duration of monitoring. If it's a moderate or severe use disorder, it's typically a 5-year monitoring period. If it's mild, if the individual does well, they can actually finish in 2. Now, if it's an impairing mental health condition, oftentimes the duration of monitoring is really driven by the recommendation of the evaluator.
Okay, so does medication-assisted treatment versus not play into how long they're monitored, or it does
not?
Okay.
Again, it just kind of goes back to what was the severity of the opioid use disorder. Presumably, if they're on buprenorphine, it was moderate to severe, which would be 5 years.
Okay. And do you talked about the nursing program. Are physicians allowed MAT as well and back to practice? Does it work the same for them?
No, we have not had a similar process with the Board of Medical Examiners. Participants would present before the Board of Medical Examiners in those instances for further discussion.
Okay. All righty. Do you have any statistics on the rate of long-term recovery for those that go through the program in South Carolina?
Don't have long-term statistics. I do. We keep statistics about recurrence to use of our participants that are currently in the program. Just honestly, it comes down sort of a logistics issue. Tracking people after they're done can sometimes become or be sort of a bear, but our reoccurrence rates in our program, they typically hover around 15%.
Okay.
While they're in the program. And we could break it down by, what year does that typically happen in, those types of things.
Mm-hmm. Yeah, that would be interesting, actually, what year it happens in. I think that's one concern when they're back to work, how long do we need to treat this person as, different? We need to really keep an eye on things extra versus, okay, now they're good. They're good to go. I don't know when that happens. It's probably different for everybody.
It is. And too, I think it is absolutely influenced by what does access look like?
Sure.
What was the, what substance did they use disorder? What type of substance was the use disorder? Also too, and you've probably found this in looking at all the different states and their programs, some states actually start the monitoring when the individual is, or the monitoring duration is measured while the person is in practice. So their monitoring period, for instance, wouldn't start until they resumed working as a nurse, and then that monitoring period, say, is 3 years. So it's 3 years working as a nurse monitoring. We don't have that in South Carolina. So once the individual, signs the monitoring agreement with us, monitoring starts at that time, whether they're practicing in their field or not.
Okay. Yeah. And it also varies, I'm sure, with how much help they're getting for that mental health piece of it, right? Are they addressing their issues, the other issues that go with that? Okay. So I always like to kind of humanize substance use disease for our listeners, because I just think that gives a bigger picture, and it also lends the facility to being more open to the reentry process if we realize that, this is just another disease. And while, yes, it does affect patient safety, we can do things to mitigate that risk and also do something for the healthcare professional. Do you have any stories that you can share with us from those who went through your program and just had their lives changed with recovery?
So I've given this some thought. I don't have any one particular example. I think what strikes me the most, so I'm approaching my 4th year in this role. What strikes me the most is at the end of a monitoring agreement or monitoring contract, we do an exit interview and ask lots of different questions. What could have been better? How can we improve? What, and oftentimes the feedback that we get is, I was angry. I was upset in the beginning. Didn't understand, why I was being asked to do some of these things. And then, at the end of it, they say, thank you. This saved my life. If I didn't have this accountability, even though I came in kicking and screaming, I got the treatment that I needed. It saved my life. I have relationships now. I have stable employment. I have my self-respect back. That's the theme that's heard time and time again in those exit interviews, is I didn't want to be here initially, but now I'm, eternally grateful. And oftentimes we, at the end of monitoring, professionals say, tell me who I can talk to. Like, I'd love to talk to new people coming in and let them know, I was scared too. I was fearful, but it's going to be okay. And actually it's going to be, things are going to get better. You can get back to life. And I think that's, every time one of those is conducted, and we look at those on a quarterly basis, the feedback coming back from that, because we're constantly looking on, at ways to improve. But, so that's always encouraging to hear.
Yeah. And that is a message that I have heard time and time again. And I think that also is important for those at the facilities or that suspect that somebody has a substance use disorder. What you tend to hear is, oh no, but what if I'm wrong? And, oh no, I don't want to, rat them out, or, oh no, that's not my business. But you're not doing them any favors. They've got to get to the point where they get help and then come out the other side, and they will eventually, they won't at the beginning, but they will eventually then appreciate how the person who initiated it essentially, right, and got them where they are, because it had to start. Somebody had to kind of force their hand to get them started.
Well, and I
So
think too, if there's a fear of what if I'm calling something that isn't there, that's okay. Like that's part of the reason, at least in South Carolina, that we do the
Yeah.
evaluation is to determine, is there something there? And like I said, sometimes we find, there's not. And
Right.
so I'm just trying to allay some of those fears. Because I can understand, I talk to medical students a lot about professional impairment and in medicine, and I use that term sort of globally. So pharmacy, nursing, whatever the profession is, but in medicine, I think we have this culture in which we're fearful to say anything to our peer for lots of reasons, right? Whether that means we're wrong, whether that means that, oh gosh, if this person goes out, then that's more work on our end, or maybe there's so many things that I think people have, fear of in the health professions when broaching this topic of potential impairment.
Yeah.
Hopefully with time we can begin to, allay some of those fears.
Yeah, agree. And that's one reason why, I wanted to talk to each of the states and find out what their program is, because I think that if you're isolated in a facility and you're monitoring for and finding these people, and then you're just not sure what happens after. And so I think knowing the big picture, knowing that in South Carolina, at least, that there is a solid process and people won't be accused needlessly if that's not the situation. They'll go through the assessment and then get help in other ways if there's something else that is going on and it's not a substance use disorder. But if it is, then they get help for that. And then that was a good thing that they got started on that path. So
yeah, and it's not uncommon, when someone does have an evaluation, maybe they do identify some problems, but those aren't necessarily something that warrants monitoring. So whether it's, undertreated depression, unidentified anxiety disorder,
Sure.
we have that happen often. And the participant that had the evaluation
Gets
at that
help.
point, they would be our prospective
Right.
participant. But, they say, oh, well, I talked with this evaluator and we were talking about what are the criteria of generalized anxiety disorder. I didn't know. I just thought I was high strung,
Right.
whatever. So it gives them a piece of information. And we try to obviously, choose good evaluators that can be thorough and consider all the potential factors that may be contributing.
Sure. Yeah, that all makes sense. Okay. Thank you very much for your time today and for sharing with us. This was great. South Carolina does some really great things, all the way from, the DHEC partnering with the hospitals for the investigation, and your program sounds extremely solid, and it's great. South Carolina has stuff to be jealous of, I think.
Oh, well, we're proud of what we do. We love the work that we do. We find it very meaningful, and we're, constantly looking at best practices and how we can reach that for our professionals in our state.
Yeah, I think it's great. All right. Thank you very much, Dr. Payne.
Thank you.